using this. Okay, so thank you very much for the introduction, and wonderful to be invited to give this talk. It's a bit of a theme this afternoon on long acting, but I'm going to take my viewpoint about this, and what I'm going to do is I'm going to hopefully update you on where the drugs have got to. So there are my disclosures. So first of all, is there a need for long-acting antiretroviral drugs? We have to ask ourselves that. Okay, and the current drugs are cabotegravir, rilpivirine, and there's some new data on lenacapavir. And then I'm going to talk about islatravir, is it back on track? And you've heard a bit about BNABs, or a lot about BNABs today, and I'm going to talk about those in treatment. So we've got these, right? We have 10. I'm not saying they're available everywhere, because in the majority of the world, there's only one. But these are the sorts of all approved drugs that someone like me in Europe or people in the US or other countries can have. Okay? And many have got no food restrictions. There's several with almost no drug interactions, few adverse events. Some are almost resistant proof, not quite, but almost, and some can be used in second and third line. So we've got a lot of therapy at our disposal to be able to give to patients. And here's the injectables, which are long-acting. My friend, great friend and colleague, Martin Pozniak, talked to you about CAB-LA and rilpivirine LA, and I'm going to talk about those in a different way in a minute, and also I'm going to talk about lenacapavir and other things. So the injectables that Marta said, there are, and I've been asked to talk about challenges. You've heard all about the advantages, but some of the challenges I am going to go through, right? And one of them, yet they're not approved for use in pregnant or breastfeeding women, and there's limited data on children, but it is coming, okay? And I'm also going to talk a little bit about resistance also about the fact that there are challenges, administration of the drug, delivery and visit challenges, but the other big challenge, especially for lower middle income countries, is cost. So let me cover some of those things and give you my viewpoint on those. So it's fantastic number of trials that ViiV have done on CAB-LA, and it's non-inferior to oral art, and Marta's told you all about that. Okay, and that patients prefer it, but remember, the patients that go on it wanted to go on it. So, you know, you have to remember that that's always a little extra thing that bias that a little bit. Okay, so now resistance. Even if you take your injection on time, every time, there are some people who have virological failure and get resistance, and it's approximately 1 in 70 at year 1 and 1 in 60 at year 2, and we don't know quite why, whether it's PK, I mean some people believe it's that, or other factors involved. So if I gave you a triple drug therapy that's highly effective that people take every single day, you won't see that, right? You won't see it. Okay, we have got data on switch. We've got some data I'm going to show you with those with poor adherence history, and somebody mentioned about the San Francisco data, so I'm going to show you that. And there's some more data on starting in naives, a little bit of the pregnancy data, and the real world. But if you look at all of that, the only license recommendation at the moment is switch when undetectable. All right? All the rest of those, right, we don't have indications for. And obviously, we really need to look at access to these therapies worldwide. And also, what about having formulations which are longer than 2 months and subcutaneous? Well, we are not there yet. You can give it in the thigh, but only about 40% of people thought that was a good way to administer it. That you can do it, right? They found it very painful, a lot of the others. Okay, so Marta touched on this. So if you're going to develop a clinic where you're giving antiretrovirals long-acting with cab and rilpivirine, you've got to be very well organized. And it's taken us at Chelsea, as Marta said, a while, but we're really well organized. But if you are a single-handed, or you're there with one nurse or two nurses, you really have to train somebody very well, right? You really have got to do that. And if they go on holiday or they're sick or something else and patients are coming, you really need to make sure that the whole team understand what it is to go on injectables. And there's a great blueprint from Chelsea that Marta showed us. So the first thing is that obviously if you've got resistance to rilpivirine, you're not going to give it. Now the next thing is this HIV-1 subtype, which is in Eastern Europe mainly and parts of Africa. It's probably not so important here in Latin America, but not many people actually get a result back on subtypes more than just subtype A. They'll just say, so, if you ask, can I know which subtype in A? Is it A1 or A6? You have to get them to specially look at the sequence to do that for you. So don't think when you get a resistance test back on a patient or got one from the history, right, that you're going to have that. The other problem is if they're undetectable and they've been on dolutegravir, say, from the start, or bictegravir from the start, and never had a resistance test, it's going to be very difficult to know what clade they are. And then the last thing is the BMI, and obviously if they're more than 30, you've got to give a big, long needle. Okay. Now, so if you have any of those factors, things can not work out as well, and if you've got 2 or 3 of those, well, that's a problem. So you do need to know about these, but in most situations in the world, the only one of those that we've got data on is baseline BMI. Okay, that's it. And you can overcome some of that with a bigger needle. So who can you switch to? As Marta said, the guidelines all say now, they've all got CAB-LA, EACS has, IAS, DHSS, so that's all fine. Okay. And this is just quickly to recap on the SOLAR data. If you're on a triple integrase-based regimen and you switch to CAB rilpivirine, it works just as well. You can see here the undetectability rate, the virological success, and also, if you look on the right, okay, the proportion with the failures, you can see it crosses over, okay, from the point estimate, that it's non-inferior. So you can, if you want, have somebody who's undetectable, who's never failed on a rilpivirine or got any mutations, and imagine you've got no resistance tests whatsoever. It's possible you could switch them to dual therapy with injectables. What about outside of clinical trials? We saw some of this, but when you look about patients, what they actually do, you can see that some people come in early. This is in Germany, and we have this impression that Germans are very good at timekeeping, right? They're very good at coming to the clinic, but it's just an impression. But when we look at this, if you look at in the red, the people who come in late, about 1.4 plus 1.4, 2.8% of people, right, are coming in late. Now, if nearly 3% of them come in late, you then have to think about the bridging, you have to think about what to do with them, you have to think about are they going to fail therapy, etc. And when we look at the virological outcomes, they're pretty good. There was one virological failure in that time, and most people were undetectable. So, and if you look at the person that had virological failure, they developed INSTI mutations, and they developed NNRTI mutations. And so this hasn't got a very high barrier to resistance. If you get virological failure, you can see you're going to get resistant mutations. Okay, and this person, just to remind you, had their injection in the window time. So this is really one of the big issues for me is this problem of being on time and still having virological failure. It's rare. You can see here it's 1 in 200 in this series out to 6 months, but it's something to consider. So if you're going to set up a service doing this, you really have to have everyone trained, the patients all understand what to do, but you may see virological failure in spite of that. Now here's I've looked and looked and looked for more pregnancy data, and I can't find much more pregnancy data than this. And these are the pregnancy data, and it all looks good. If you look at the pregnancy outcome, normal birth, normal birth, normal birth, there's one with low birth weight and one preterm. There was this issue with integrase inhibitors, and are they related to preterm births? But maybe all antiretrovirals might be slightly associated with that. But it's encouraging, but we need more data. Now, we've already seen from the previous talk about monitoring, but I reiterate that if you're not in the clinic as the physician and the nurse is in the clinic, they need to know what to do if somebody says, I can't come in, I can't do this. Somebody's on the phone, or somebody's saying, I can't come in next time, what do I do? I've always said that if you go on injectables, you should have at home at least 1, maybe 2 months of your previous medication. I mean, you could give them Cabril, Pivarine oral as recommended, but why not have your previous one at home? You know how to take it, you know you're not going to get side effects, you know everything about it because you've been on it for a long time. So this is a suggestion I say to patients, because they say, I've got 2 months left, shall I bring it back in and you can dispose of it? I say, no, keep it at home, because if you can't make the appointment, you can start on the orals. So that is something to consider. That's a completely off-label comment by me, okay? But it is something to consider when you think about starting patients on injectables. Now, this is the sort of, this is the Ward 86, and we had a question about the San Francisco data, and these are people, if you look in the blue there, they're around 45 years, most of them are men, and they're a mixture of white, black, Latino, multiracial. Now, most of them had unstable housing or homeless, a third of them were taking crystal meth or other stimulants, and I'm going to show you the data on the people who had detectable viral load in a minute. And you can see there were 2 groups. Those who had suppressed viral load, nice CD4 count, 600, and those who were non-suppressed with a lowish CD4. Now, when they went into this project, they were given a lot of social support. So these aren't just people where you're homeless, it's difficult to take the drugs, it's hard work, therefore we're going to put you on injections. We're going to put you on injections and also give you a big social support. So that costs money, right? And that costs effort, and there must be a department or people to do that for you, because if you don't, then maybe you don't get these results. What's happened there? Okay. Well, they got, I'll go back. There we go. They got 98% viral suppression, 98 in the left-hand column. Most of them came with on-time injections, right? And the virological failure rate was 1.5%. And they had early virological failure in 2 patients, and I don't think they had mutations, but I haven't seen that data. So you can see you can do really well with people who are disadvantaged, homeless, taking recreational drugs, right, etc., etc. So, but you need to give them a support package on top. There's no control arm here where they say, this lot had a lot of support, and this lot over here, we gave no support, extra support to. No, they all got support. Okay, so let's now look at the people with uncontrolled viremia in this cohort. And here they are. So if you look on the right, most of them became undetectable, 97.5% over 33 weeks, and there were 2 early virological failures. And if you look there at the mean log viral load, it's 4.2, all right, and the CD4 was 215. Okay, so 4.2 logs, that's about 10,000, it's probably about 40,000, yeah. Okay, and what was great about this, in a way, was that for nearly 20% of the patients, it was the first time they'd ever got undetectable. So that's a huge boost. So this is a great strategy, I think, to be explored more, to do more research on, but it comes with that caveat that people can't just be told, we're just going to give you an injection, you'll be fine. It's got to be a lot more, right, about the way that they are supported in the community. But it has, so at the moment, this long-acting is given to people, as I say, who are suppressed, who they tell, I'm going to be adherent, I'm going to do this, I'm going to do that. And there's a big study in the States looking at people who are non-adherent to see if this works. But to get into that study, you have to be adherent first. So you're non-adherent, and they say you can go on long-acting. Oh, great. How do I get into the study? You have to be adherent. And then if you're adherent, you go. So I'm a bit uncertain what that's going to show. So it could be, though, that if we get this right, that for certain groups of patients who we've had real trouble with tablets, that this could be a game changer. And I chair a data and safety monitoring board for a big project in Africa in adolescents, right, who you immediately think of as not being very adherent, well, at least a proportion of them. So, I mean, should we give it to people with uncontrolled viremia, high risk of HIV disease progression, but have got susceptible virus, and we give a lot of management, intensive management of the case? So I think that would be really good. But what about lower middle income countries? First of all, access. I chaired a big meeting at the IAS about access just to PrEP of cabotegravir. They said then it would be up to 5 years before generic companies have got this on the market, because they all have to be pre-approved, medicines patent pool, all these other people have to approve them, and then they have to do it, right? So the problem is, imagine I'm a generic company looking to the future. I need to make some money. It needs to cost something. I have to make a factory, or I have to make a big production line. And then in 3 or 4 years' time, this drug's not being used very much because we've got some new one that's come along that's given every 6 months. So they start to take risks, the generic companies, with this. It's not like we're going to produce a pill, and if that doesn't become very popular, we'll move on to the next pill. The production cost for this is very different. Remember, there's a cold chain for rilpivirine. The other thing about access, which Marta talked about, was models of care. You do not just say, oh, okay, I'm going to start injectables tomorrow. You look like a good candidate. You want it, we'll start. Right? You really need a whole model of care. Viral load testing. This is a challenge in many countries in the world. Do you do it every 2 months? Just do it normally, every 6 months or every year? What's the best way of monitoring viral load in these patients? And of course, you have to ensure a supply of the drug. If you've got issues with drug supply, imagine there's only 1 or 2 generic companies that you can afford to buy it from that are supplying this. You've got to make sure your supply chain is absolutely intact. Also, you've got to make sure patients don't miss their appointments. For example, phoning them, texting them, making sure they're coming. And the next thing is about cost effectiveness. Governments look at this, right? People who are buying the drug for the people, right? They look at cost effectiveness. And that depends on how much is it. If it's $60 every month, maybe the cost effectiveness is wonderful. If it's $25,000, then you're going to think a year, say, or whatever, you're going to think, no, we're going to stick with tablets. So what the actual price and the cost is, okay, is going to be very important as to whether national procurement is going to go forward. Because in Africa, unless it sort of, dolutegravir now, combination in Africa is $38 a year, right? $38 a year. So they've really got to make the price of this quite low in Africa to be competitive. But it could be that in groups of patients who have difficulty in taking pills, etc., it will be cost effective rather than allow resistance. Now, the last thing I want to say about this 2 monthly long acting is we're trying to demedicalize HIV so that people who are not qualified doctors and nurses can deliver antiretroviral therapy, give it to groups of patients who turn up every month or 6 months or 3 months. We're trying to make sure that healthcare practitioners who haven't been to nursing school, haven't been to medical school, but know all about how to counsel patients and give them their pills can still do that. We're trying to simplify, which obviously injections can do, but when you think about the administration, it's not simplification. and we're trying to make sure that people can access their pills wherever they are. And so we have to demedicalize injectables, and if we go to implantables or anything else, and that is a big challenge for us. It's a big challenge because at the moment, injectables are very dependent on clinics, on doctors, on nurses, and obviously on patients. Okay, so what about islatravir? So what's happening with that? Carlo yesterday showed us about islatravir. It's a really very good drug, and it's very potent. 10 times the potency compared with some of the current ARVs. And here's the development program that was going ahead. And unfortunately, you can see here that in 2021, not very long ago, the development was halted because of a decrease in CD4 count. Okay, so total lymphocyte and CD4 counts. But now, and here is what we saw. If you look at islatravir, 60 milligrams in the green, you can see the CD4, the lymphocyte counts going down. And again, with 20 milligrams every week, you can see that's going down, okay? And with the doravirine islatravir, you can see it does go down a bit, but compared with the comparator, but not very much, few percent. But if you look at the dose here, the dose of islatravir is 0.75 milligrams, and the dose going forward is 0.25, because 0.25 doesn't seem to have a significant effect on CD4 count. So islatravir is going forward, but it's not going, it's going forward, but the once a month, right, is not. So it is going forward, and we're waiting to see what they're going to do with the implant. And I think that islatravir's got a great future, but we need to see now the clinical studies coming forward using the 0.25 milligram. So there's that once a month, program discontinued, long-acting being reassessed, highly treatment experienced with the resistant virus on hold, once daily therapies going forward, and once weekly with lenacapavir and suppress switch is going forward. So it's a good program, but it hit a few, as they say, bumps on the road. Now, lenacapavir, we saw this yesterday, and it's not just a capsid inhibitor. It also stops nuclear transport, some virus production. Lenacapavir is a very interesting drug. And the trials, though, honestly, you don't need to look at these slides because well, you can, but it's really complicated. So this is the naive patients out to week 80. And basically, you can see here that you were given lenacapavir plus FTC TAF in that blue every day, or you were given Bic TAF every day. That we can understand, okay? That's a drug all the way along with lenacapavir, and the other one with bictegravir, and one with the other group had lenacapavir, right, and FTC TAF every day, and the other ones did too, but the different dosing. And then they looked to see who was undetectable, and then they moved forward on those. So it's only if you were undetectable that at week 22 you were switched then. So basically this study is 3 lenacapavir plus FTC TAF versus lenacapavir and bictegravir and lenacapavir and TAF. It's really quite complicated in the end. So it's really looking at how to use lenacapavir in various scenarios. And that bit about the less than 50 was just a safety thing. And when you look at it all, there we go, the 4 different regimens, including the control arm in the green, you can see that, I can't give you statistics here because the numbers are small, that they're basically all looking very similar, though you can see numerically the lenacapavir and the FTAF, who switched to lenacapavir and bictegravir, oh my goodness, they didn't seem to be doing as well. So this is quite a complicated, and you really need to sit down with it for an hour or two. But it's going forward. Let's see how lenacapavir works. It's really what you're going to give it with in the future. So this is now people with multi-drug resistant HIV. And these people have got viremia, more than 400 copies. They're resistant to 3 of the 4 main antiretroviral classes, and they don't have many active agents, right? So they are so-called MDR HIV. And then just look at the orange and the blue. They're randomized to lenacapavir and their failing regimen, and then after 2 weeks, they're given subcutaneous 6 monthly, and then they optimize the background. Why do you do this? You want to see what the activity of the lenacapavir is in the first 2 weeks, because if it's not working, you probably wouldn't carry on, right? And the next was placebo and failing regimen. Right, they just followed those through, so they're on what they're on, and then they switched them to lenacapavir and then to subcutaneous lenacapavir and optimized their background. And then there was a whole group of people who hardly, when they were given the lenacapavir, they hardly went down. Their viral load went down only half a log. They were put into this non-randomized cohort of oral to subcutaneous and OBR. So it's, again, complicated. But the only real, and I think that the non-randomized cohort's there to try and so-called salvage patients, but the orange and the blue are the ones to look at because they're randomized. So these people were in their 50s. They had, about half of them had a low CD4, and if you look at all the resistance in the bottom bit there, a lot of them had that. And I was amazed, between 2 and 25 antivirals in the past. So these are really experienced. But look at the right-hand curve. You can see that actually, if you look at the proportion of people who stayed in the study that had undetectability, it was 81%. If you just look at the total number, so that's of people who stayed in the study, right, out to week 104. And in the other, you can see you get about 60% viral suppression. So, you know, if you're that heavily treatment experienced and you can optimize the background and give lenacapavir and get undetectability in that amount, that's doing pretty well. What about side effects? Not much really at all. Very few grade 3 side effects, and very much that came out that was significant. People do get injection site reactions. Do you remember T20 where everybody got an injection site reaction? And I'm sorry I'm having to look at this screen because the data is very complicated. I'd like to be looking at you guys and know it all off by heart. But if you look here in the bottom orange, the very bottom of it here, you can see that very few people got a grade 3. Only 4 people actually had grade 3 and nobody got grade 4. So it does cause reactions, but they're not very serious at all, okay? You can see that they're very mild, and if you look, most of them have none. If you look at the CD4 count, there's no, and why are people doing this now? Because islatravir had a problem with CD4, so all new drugs now, everybody's going, we must show you the CD4 count over time, and you can see in these people who are multi-drug resistant, look at this, they actually had a good improvement in CD4 of 122 cells. Now, if you had a CD4 of 50 or 60, right, and you went up 122, you'd be very happy, right? You're getting towards a threshold of being safe. So that's always a good thing. But the resistance barrier is there, and you can see that patients who fail, who have virological failure, you can see that some of them develop emergent lenacapavir resistance, especially the 66 mutation. So there were 14 people. They were at high risk for a resistance because actually they had no active drugs in the OBR. So these were people who, a lot of them got monotherapy with lenacapavir or partial therapy. And that's what you'd expect. So I would say, actually, if I had a patient like that with very little option, I wouldn't give them the lenacapavir. I'd wait until they got another drug was available, or if there was something that you could get to give with it, like fostemsavir or something else, I'd wait till I could get 2 active drugs. So it is interesting that those patients who more or less got monotherapy got resistance. So in conclusion, virological suppression in a lot of the patients who were highly treatment experienced, 14 developed treatment emergent len resistance, and some of them continued the whole therapy and went undetectable again, and it was well tolerated. So broadly neutralizing antibodies. So these are generally safe, they've got long half-lives, and here's a whole list on the right of them. And the interesting thing is that they're all designed to bind to different sites. You can see CD4 binding site, envelope, all GP120 interface. They're designed to do different things. And when you look, a single BNAb was like a single antiviral. Makes your viral load go down, and then it goes back up again. If you combine them, you get a much better virological response. And if you combine 3, you get a good virological response, but you can see some of them had rebound. So they look very interesting. And in fact, the people that you really get a lot of suppression with this are those with low starting viral loads. If you start with a very high viral load, even if you give combination BNAbs, they're at a high a risk of virological rebound. And you can engineer them more to increase their bioavailability and enhance their binding and prolong their half-life. So one of the dreams was this. You have an HIV patient, you take the blood out, you look at the virus, you design 2 or 3 BNAbs because you know exactly what all the conformation is, yeah? And you can design them, you put them together, and there you go. You've got a fantastic individualized therapy. However, taking the blood out's okay. Looking at the virus and designing these is something different, and then infusing them back in is something else. So we just have to be a little bit cautious. They may be able to be given subcutaneously. So here's this N6LS, and you can see here a single infusion in people with HIV are off therapy. Some of them had prolonged, this is just a single infusion. All of them rebounded. You can see, and one of them took a long time to rebound. And the susceptibility and time to, the more susceptible you are to the antibody, the more longer it took to rebound. So here's a study of N6LS, and these are people who are viremic, but look at the N. Only 14 people were in this study, and they were given a single infusion of 40 milligrams or 280 milligrams. It's a dose-ranging study, and then at some stage, when they rebounded, they got dolutegravir 3TC. And they did get quite good virological response. I put that there. Median viral nadir, 1.7, and some of them went down 2.6 logs. Okay? But the median time to viral rebound among the responders, you can see is up to 78 days. So they are interesting. But what can you do with them? Well, you could put them with lenacapavir. And here's a study that was presented where you give lenacapavir and BNAbs. Now you've got a triple therapy. Great. We now got a triple therapy, but this time using 2 classes of drugs, BNAbs, right, and a capsid inhibitor. That's really interesting and exciting. Now, terapavimab and zinlirvimab, thank goodness, is reduced to TAP and ZAB, right? So these are TAP and ZAB, and one is against the CD4 binding site, and one is about envelope there. So the problem is now, let's start with problem 1. I'm sorry, I always talk about problems, but if you don't see the problems coming, you can't fix them, right? So here's the problem 1. Only about 50%, just over, are susceptible to them, and more than 90% are highly susceptible. But it does mean that around about 10% aren't highly susceptible, and about 50% are not quite susceptible. So it's the way this is written. Okay, but and the other problem is you have to give them by infusion, yeah, and you do it every 6 months. And here's what you do. And if you look at the little box at the bottom, you can see where you get oral lenacapavir, subcutaneous lenacapavir, and then the infusions of TAB and ZAB. At least there's only one infusion. And this is what they did. Okay, so it's basically either you got len and tab and zab at that dose, or len and tab and zab at the other dose, the 30-30 or the 30-10. Okay, well, what happened? Well, first of all, it seemed to do quite well. This is week 26, not week 52, not week, they haven't had a second dose. This is just after the first dose. Now, the problem for me, again, here we go again, problems. 18 out of 20 maintain virological suppression in a triple combination therapy out to 26 weeks. Okay, well, I don't know whether I'm very happy about that. One person had confirmed virological rebound and then had to go on to oral therapy. So and you see around about 10% of people it's not working in. Now, if I said around about 10% of people starting on a dolutegravir or bictegravir-based regimen or doravirine with that, you might not be so happy with it. So I'm not sure where this is going. Subcutaneous injections and infusions, right? Not everyone's susceptible to them. Virological failure rate around 10%, even at 26 weeks. And they've been given the drug, remember, because once it's injected and infused, it's not like they haven't had the drug. They can't complain of non-adherence here. Okay, so this to me looks a little like it probably won't go forward as it is. And when you look at the PK was fine. So I don't know, there's the dotted lines above which all of this was. So it didn't seem to be so much a PK thing, much more likely that it was a susceptibility thing. Remember, HIV is replicating in these patients. All the mutations are occurring, and maybe there was a small reservoir of non-susceptible virus that outgrew, and therefore someone failed. So let's see. So I'm nearly at the end now. So what we're now coming in for long-acting is technology for drug delivery. We know about intramuscular. We know about subcutaneous. What about drug patches, okay? All sorts of drug patches, all sorts of implants. This thing you can have in the stomach that stays there for a long time. I'm not quite happy about that. Some foreign body in my stomach for 6 months. I can't believe what that could cause. Infusion pumps. I haven't talked about vaginal rings because that's in PrEP. And then, of course, implants. And there are all sorts of implants. Ones you can remove and ones that dissolve. And there are issues with implants as well. But I'm not going to go into big detail about that. But here's an implant that can combine several drugs. It's long, ultra-long active, tunable. It sounds fantastic. This is like buying a car. It's tunable, biodegradable, removable, controlled release, all right? Gets into 5th gear in 10 seconds. But it looks fantastic. And the drug concentrations for 1 year. So this looks marvelous. And I think that this is potentially the way a lot of medicine might go if the technology improves and they actually do it. And look at this. These people have got this novel formulation which have transformed 3 HIV drugs. Look at the names of these drugs. Tenofovir, lamivudine, dolutegravir, from short-acting to long-acting, all in one injectable. So that's interesting too, huh? That you get a triple therapy this time that we all know about, and patients, most of the world is on it, and you give it as an injectable. So things are moving in this field really in an interesting way. But in conclusion, the problem is, I suppose, that we haven't got a big pressure on trying to develop new HIV drugs because we've got lots of them that work very well. That's one thing. The pipeline isn't so robust. I showed you the BNAbs. We saw what happened with islatravir getting stalled, yeah, and there's all sorts of things and people have tried the thigh injections of cabrylpivirine, etc. So there are things that are going on, but we haven't had a lot of real big advance. So problems continue, but really, even if you had now 6 monthly subcutaneous injections, you need to make sure that you can implement it, okay? So with the cabrylpivirine, there's a lot of implementation. There'd be much less if you had even just subcutaneous or even implants. But there's still a challenge for us to do all this in the clinic, which of course we can do. I think there's an uncertain clinical path for BNAbs alone. There is some promising result from the combination, but it's not perfect yet, and I'm not sure where these will go. And in the end, I think the future, as everybody said, is probably 2 drugs. It could be 3, but it's probably 2 drugs. But I think that we now need to get soon to the next phase of long-acting so that it's easy, it's convenient for patients, it's convenient for us. right? It's got to be convenient for us, because otherwise if we have a lot of challenges in the clinic, we'll start saying, oh, I'm just going to give them a tablet. It's so much easier. That cannot be the mentality for Cabril Pivarine. It cannot be the mentality. It's got to be, what do you prefer? What choice do you want? And let's try and make that happen. Okay, and with that, I'd like to say thank you very much.